This video is going to focus on Chapter 7, the bone tissue as it relates to the skeletal system. As a reminder, you should be using the reading guide and the review guide to steer your studying and utilize the resources from your textbook, as well as your thinking about worksheets and your discussion boards. So let's focus our effort on what I mean when I say the skeletal system and the functions of the skeletal system. So the picture here is showing the axial versus appendicular skeleton. And for the purposes of our lecture, you are not expected to know all the terms that go along with the names of the bone, but I do want you to be aware that our skeletal system involves not only just the bone organs themselves, but also other connective tissue, including your cartilage and your ligaments. So cartilage is really important in actually forming the bone of our body and is the precursor to most of the bone deposition that happens in our body. The ligaments are the material that is connecting one bone to another at joints and holds them together. Those are not to be confused with tendons, which tendons are the extensions of the fibrous connective tissue from your muscle to connect to the actual bone. So the functions of the skeletal system involve the support of our bodies, thinking about your limb bones and your vertebrae, how your jawbone also supports your teeth. Technically, teeth are not considered bone, but they are supported by your jawbones. Some of the bone also supports our visceral organs. Now, the skeleton does also offer a bit of protection, including the cranium that surrounds the brain, the vertebrae that surround our spinal cord, the ribs that protect our heart and our lungs, and other regions of our body are also protected by our bones. The skeletal system also functions in movement because our limbs are able to move, our thoracic cavity is able to expand to aid with breathing, and other movements depend on bones in our body. There's also a really big role in homeostatic mechanisms, including electrolyte balance, which specifically we focus on calcium and phosphate levels in the body. And then there's the acid-base homeostasis, which the bone can actually buffer our blood against large pH changes by altering the phosphate and carbonate salt levels within the blood. The bone marrow is also really important in producing our blood cells. So when we are dealing with the skeletal system, I want you to be aware of what's involved with it and its functions. So what I want to start out with is focusing on the anatomy of a long bone. And what's pictured here is actually a femur. And when we look at the femur, you can see that it has two enlarged areas at either end and a shaft down the middle. The technical term for the ends are the epiphysis for one of them, or epiphyses if you're dealing with both of them, and then the diaphysis is the shaft. And what is typically housed in a epiphyseal region of a bone is your spongy bone, which contains red bone marrow, which red bone marrow again is responsible for production of our red blood cells. And then the other bone marrow is present in our diaphysis, in the medullary cavity or the marrow cavity, and this is where the yellow bone marrow is. Yellow bone marrow is a fat storage region, and during cases of chronic anemia, the yellow bone marrow can get converted back into red bone marrow as necessary, but it also adds a little bit of a cushioning mechanism inside the bone. Surrounding the bone is a thin tissue layer referred to as periosteum, and the periosteum is really important in creating bone cells, which we'll talk about in just a moment. Endosteum, which is the internal lining of your bone, is also an area that is responsible for producing some of our bone cells. The other thing that I want to point out is that at the ends of each of the long bones, so in the epiphyseal regions, you'll see a layer of hyaline cartilage, specifically articular cartilage, that helps to provide some lubrication between it and another bone that it comes in contact with to help with movement. And we can also find articular cartilage in the epiphyseal plates in immature long bones, which we'll talk about in a little bit as well. The other thing that I have not mentioned that is on this picture is showing the nutrient foramen. And basically that is a minute hole in the bone surface that allows blood vessels to penetrate, because there is a lot of vascularization in our bone, which is one of the reasons why bone tends to heal faster than cartilage damage or tendon or ligament damage. When we switch gears and we look at flat bones are bones that you've got spongy bone sandwiched between compact bone, and this is primarily found in our skull bones. It's also in our sternum and our clavicle. So you've got different variations of bones within our body depending on their structure and their function. So let's switch gears and talk about the actual histology of the osseous tissue. So this picture is showing 4 different types of principal cells involved in bone. The top image is showing how do we actually get a mature bone cell referred to as an osteocyte. Well, first it starts as an osteogenic cell, which is a stem cell found in endosteum and that inner layer of the periosteum. And it comes from an embryonic tissue referred to as mesenchyme. And they go through mitosis fairly readily and keep multiplying continuously to give rise to most of the other bone cell types. So osteogenic cells, when it goes through mitosis, will produce osteoblasts. Osteoblasts are bone forming cells, and they will form the single layer of cells under the endosteum and periosteum, and they synthesize a soft organic matter of matrix that hardens through mineral deposition. It's technically osteogenesis, when you have the hydroxyapatite being produced and hardening around them. The osteoblasts will also start to deposit more bone matrix material when there are stressors involved. And when the bone matrix becomes hardened around the cell is when we refer to it as an osteocyte. Basically, the osteocyte is the mature osteoblast that is now stuck in a lacunae, and it develops these little channels called canaliculi that attach one osteocyte to another osteocyte. And that's how nutrients can get to them, wastes can get taken away, as well as getting additional signaling from different cells. The other type of cell involved in our bone cells are osteoclasts. Osteoclasts develop differently than osteoblasts and osteocytes in the fact they come from stem cells primarily from your bone marrow. And that would indicate that they originate along the same lines as our blood cells do. But the osteoclasts are these really enlarged cells, and they tend to be just inside the periosteum. And what their job is basically to dissolve the matrix of bone material found on the bone surface. So as you're kind of looking at this, what the osteoclast job is to help with remodeling of our bone. And if our blood calcium levels get too low, they get stimulated to break down the bone to release some calcium. And the bone itself, the integrity of it is based on the balance between osteoblast activity and osteoclast activity. I also think of osteoblasts because there's a B as osteobuilding or bone building, and osteoclast, I always think of the C as like a catastrophic event where it's breaking things. So osteoclast would be the catastrophic catastrophizing the bone material. So when we look at the structure of a bone, there is spongy bone in the epiphyseal regions, which the spongy bone basically is this mixture of spicules or extensions of the hard material and the trabeculae, which are the connections between those areas. So spongy bone we'll come back to, but I want to focus on the compact bone, which is the really, really densely packed cells along the diaphysis. So I'm going to switch to the next slide. And in the slide, you can see that there are these units that are being identified in the compact bone referred to as an osteon. This is a bone unit that there is a central canal in the middle that allows blood vessels and nerves to travel through. So there's lots of ability of nutrients to make their way to the bone, as well as take waste away and communication signals and hormones and everything that is needed for maintaining homeostasis within our bones. The bone itself, to create these very distinct concentric circles, the concentric circles are referred to as the lamella, and this is based on bone deposition because the bone deposition is happening from the endosteum and the periosteum. And as a osteoblast is depositing the material around it that hardens, when it becomes trapped in its own matrix, we refer to it as an osteocyte. And those little channels are what connect one cell to another. And the channels, again, are referred to as canaliculi. So the way a bone is structured, especially a long bone, has to do with its relation to mechanical stress. So mechanical stress is what allows bone remodeling and structure to take place. And if you look at the diagram here, you can actually see that in the epiphyseal region, that there are areas of the spongy bone where the trabeculae are more spaced out versus really compact together. The more compact nature is based on where the stress lines actually are. And then as the weight gets distributed through the spongy bone, this lattice of bone is covered with endosteum. You've got slivers of bones. Those are the spicules, and the thin plates or beams of the bone are the trabeculae. And the spaces are filled with material, which is the red bone marrow. There's not very many osteocytes. There's not as many osteons in your spongy bones, and there's no central canals to them. All of the osteocytes in this area are able to be nourished by the marrow in those regions as well. So spongy bone, what it actually does is it provides strength with minimal weight. And those trabeculae, they definitely develop along the stressors. In our discussion board for this module, you have also been asked to explore Wolff's Law, which Wolff's Law of bone is that the architecture of bone is determined by the mechanical stresses placed on it. And remodeling is this balancing act between your osteoblasts and your osteoclasts, and you will get larger bony processes developing in response to mechanical stress. So if we look specifically at the head of our femur, the head of the femur is what actually rests in the acetabulum of our pelvic girdle. And we have a lot of our upper body weight resting right on that area. The weight needs to get distributed more evenly so that way our legs can support the rest of our body. The compact bone along the diaphysis helps to resist essentially the pressure of our own body weight and gravity on our body. Now, the other interesting thing with the distribution of spongy bone versus compact bone is if we're trying to disperse weight, spongy bone is better. If you're trying to increase the strength of a bone with regards to your long bone, that weight gets distributed, and then the compact bone is kind of the final point of where the stress is positioned. If you end up having somebody accidentally kick you from the side, the compact bone, the way it's oriented, its strength is a vertical strength. So if there was a lateral force, it would easily break that bone. However, the spongy bone, if it got a lateral blow right in the hip area, this would be able to distribute that pressure more than the compact bone. So lateral forces are not good for the way that the compact bone is actually oriented and would end up breaking. Now, I keep talking about bone marrow, and I want to highlight this, that as an adult, our distribution of red bone marrow tends to be condensed to the axial skeleton. And you can see that it's also at the proximal ends of our humerus and our femur. And that's where most of our blood, our red bone marrow is found, and the production of our blood cells comes from. The yellow marrow is a fatty marrow. It's not going to produce the blood. And I've already mentioned that it can get converted back into red bone marrow if somebody is suffering from chronic anemia, but primarily it's there as a cushioning and support mechanism. So where does this bone actually come from? There are really two methods that we look at for bone development, and this starts in utero, and the osteogenesis happens either as intramembranous ossification or endochondrial ossification. Intramembranous ossification is what produces your flat bones, such as those found in the skull, the clavicle, also part of the mandible in the fetus. And this helps to thicken long bones throughout the life of the long bone. But I want to try to orient you to the diagram in your textbook. And I know that you all can read, so I'm not going to just go through the step by step. But if we look at this first one, you'll notice that there is mesenchyme, and mesenchyme again is embryonic tissue, and that embryonic tissue has mesenchymal cells. And in areas where bone wants to develop, you'll have these blood vessels, and your mesenchymal cells will differentiate into osteoblasts. The osteoblasts will start to line up along the blood vessels. You can see that happening around here and up here. And as they're doing that, they are secreting a matrix material. What they initially start to secrete is more a soft collagenous osteoid tissue. We refer to this as pre-bone, and it resembles bone, but it's not calcified yet. Then this process just keeps happening where you have more and more mesenchymal cells becoming osteoblasts. Those osteoblasts will continue to secrete the matrix that's collagenous. And then as the collagenous material starts to calcify, it traps the bone cells and turn the osteoblasts into osteocytes. So at this stage, you are starting to see the bone trebuchet, or the extensions of the bone that are connecting one area to another. And you keep getting this secretion almost of your osteoblasts and its material getting trapped, and then continuing the process. Then, while this process keeps happening, so these two processes keep happening actually, you have more mesenchyme that essentially produces the periosteum, and the periosteum is the surrounding bone tissue, which then can continue to produce more osteoblasts that then get trapped and form your osteocytes. So the periosteum, as it keeps secreting its own layer of osteoblasts, it develops into the compact bone on either end. And in the middle area where you had the initial blood vessels got trapped by the developing osteoblasts and the trebuchet was hardening, you get your marrow spaces. And that is what leads to our flat bone development. Now, The other end of the spectrum is how do you make a long bone? And that's the endochondral ossification. So this also starts out with cartilage, specifically the hyaline cartilage. And in this, the mesenchyme is developing a cluster or body of hyaline cartilage, and it has a fibrous cover around it referred to as the perichondrium. The perichondrium has the ability to create more cartilage cells. And this is the very, very early stages of development that our bones start out as cartilage. And then as cartilage cells mature, those chondrocytes will start to increase in size, and each cell is surrounded by this thing called a lacunae. The lacunae will start to essentially fuse together and create a marrow cavity. In this marrow cavity, you also have a blood vessel infiltrating, and the blood vessel is able to bring in osteoclasts, which we've already talked about where osteoclasts came from. The osteoclasts will break up the calcified lacunae connections and develop the actual cavity itself. The perichondrium gets converted into periosteum, where it starts to produce the osteoblasts. The osteoblasts will continue to deposit bone material surrounding the chondrocytes in the middle and creating kind of this ring, or a napkin ring is the way your book describes it. So this process keeps happening. The chondrocytes get bigger, lacunae start to fuse together, creates the marrow cavity. As they calcify, the osteoclasts from the blood will break that down, and then the osteoblasts from the perimeter will deposit more bone material in a more standardized fashion. This keeps going from the inside out and causing the elongation and the thickening of the bone. And then a secondary ossification center will develop in one of the epiphyseal regions. It'll go through the same process we just talked about. When that cavity gets infiltrated by your blood vessels, you end up having osteoclasts working with osteoblasts to continue developing the spongy bone in those regions. And then the opposite epiphyseal end will have the same thing happen. And we have these regions of what we call metaphysis, which I'll show you a more detailed picture of that in just a moment. But this is the residual cartilage that is then used during development once we're born through about our early 20s to elongate our long bones. And the only residual cartilage is that of the epiphyseal plate region and the articular cartilage on the ends of the long bone. So I want to take a moment and talk more about the zone of metaphysis, which this is described pretty well in figure 712. And we're looking at an epiphyseal plate, and in the middle, that's depicted as blue, that is where our reserve of cartilage is, and the area of purple is where we are having the conversion of the chondrocytes into bone. So in this diagram, you can see that you've got your reserve cartilage, and then you've got a zone of proliferation, which is where mitosis is taking place, and we're producing more and more chondrocytes. And then you get to the zone of hypertrophy, where the cells are no longer going through mitosis, they're getting bigger, the lacunae are expanding and essentially thinning. And then you get a calcification process happening. And that happens between the lacunae. And then once you have the hardening process, we go through the zone of bone deposition, which is chondrocytes die. And then you get your osteoblasts that are truly producing the trabecuae of your spongy bone. So it's a pretty interesting bit. About 10% of our bone gets remodeled throughout the life cycle of our bone every year. And when I'm talking about bone widening and thickening, this is focusing on how we have absorption of material and deposition of material throughout the life of the bone. And one of the best things to do to maintain strength in our bones and integrity of them is continue to eat properly and exercise on a regular basis, because that helps with the remodeling process. Focusing back on Wolff's Law, the structure of your bone is determined by mechanical stresses, and this relates directly to use and disuse of bones. In elderly individuals, when they are not as active, they have more issues with things like osteoporosis and things of that nature, because their bone is no longer depositing as readily, but it's breaking down more. All right, so let's talk about how bone relates to the physiology of our body. And I want to focus primarily on how it's a metabolically active organ. Not only is it involved in its own maintenance of growth and remodeling, but it has a really, really profound influence over the rest of the body by exchanging minerals with tissue fluid. If we have calcium homeostasis disturbed in our body, the skeleton will start to release calcium when it can, and without the proper amount of calcium in our bloodstream on a regular basis, we can have a disruption in the function of other organ systems, including our nervous system and our muscular system. So let's talk more specifically about calcium homeostasis. Calcium itself is needed not only for the structural integrity of our bone, but it's needed in neuron communication. It's how signals are able to get sent from one neuron to another. Muscle contraction, calcium is actually the initiator molecule for being able to start a muscle contraction and allow for the muscle to relax when it gets resorbed. It's important in blood clotting. It's important in exocytosis. So the minerals that are deposited in the skeleton are there for storage and function within the skeleton, but they get pulled out like it's a bank when they're needed for other purposes. So if we look at calcium homeostasis, it's actually maintained by hormones, and about 18% of our skeletal calcium gets exchanged with our blood each year. Most of this exists as what we call hydroxyapatite, which is a combination of calcium and phosphorus. That is not as easily exchanged within the blood, but when we are just talking about calcium, that can get exchanged pretty easily. So a couple of things. Calcium homeostasis, we want to keep it between 9.2 and 10.4 milligrams per deciliter. If you have blood calcium levels dropping below 9.2, that's hypocalcemia. If it goes above 10.4, it's hypercalcemia. And I'm not expecting you to know the values of this, but I want you to have an idea of what happens if calcium drops too low. What honestly happens is the membrane potentials of excitable cells can either become overly excited in your nervous system, or it can cause tetany, which results in overly excited muscle cells and therefore muscle spasms. If a laryngospasm happens, which is in your larynx, it can cause suffocation. If we are looking at these deficiencies, often it's caused by vitamin D deficiency, could also be caused by diarrhea, thyroid hormones, or underactive parathyroid glands. Pregnancy and lactation can also increase the risk of hypocalcemia because the fetus is going to be taking more of the calcium from the mom. Lactation during infancy, that can also cause some depletion of calcium. And we can often combat it by taking vitamin D supplements and maintaining our diet, getting enough calcium in our regular diet. If you get too much calcium, it's hypercalcemia. And what that does is it makes ion channels in excitable cells less responsive. So your nerves and your muscles don't respond as readily. So you might get muscle weakness, sluggish reflexes. It can also cause cardiac arrest and emotional disturbances. But hypercalcemia rarely occurs because our body's excretory systems tend to excrete the calcium more readily than before it becomes a problem. So this diagram is showing that our calcium intake is through our dietary requirements, and excretion happens essentially through our kidneys because our blood gets filtered. So how can you get your body to take in more calcium? Well, calcitriol is the hormone that actually increases the amount of calcium that gets absorbed by our digestive system. That's kind of the primary action of this. Calcitriol is actually the most active form of vitamin D, which, if you remember from the integumentary system, that is formed from our skin. And I'll talk about that in just a moment. I have an image to show the progression from our skin to its final actions. So first, we absorb more calcium through our diet. And then once there is an excess of calcium in our blood, that triggers another hormone to cause bone to be deposited. So you actually are forming the bone. And there's the hydroxyapatite form, and there's the calcium carbonate form. And calcitonin is the hormone that does actually increase your osteoblast activity. Calcitriol, if you don't have enough calcium in your body, will cause us to resorb bone through osteoclast activity, and that works in conjunction with the parathyroid hormone. So if your levels drop below what they should, we try to get it through our diet, but if you can't get it through your diet, we extract it from our bone. And as far as the kidneys filtering our blood, if you have too much calcium, it gets secreted out our kidneys. But if we don't have enough, calcitriol and PTH both cause the kidney to reabsorb the excess calcium, so that way it stays in our bloodstream. So it's definitely this balancing act. So there's 3 hormones involved. There's calcitriol, there's calcitonin, and there's parathyroid hormone. Calcitriol and parathyroid increase your blood calcium levels. Calcitonin reduces your calcium levels. So calcitriol, where does it come from? Well, it starts with its precursor molecule in our skin. The UV light comes in and basically warms the molecule and catalyzes it to become vitamin D3. Vitamin D3 is then converted in our liver by adding a functional group. Then it's finished converting in our kidneys to become calcitriol. Calcitriol influences bone resorption, so taking calcium back out of the bone, reducing how much is excreted, and absorbing more through our digestive system. The other 2 hormones work in conjunction with calcitriol, specifically parathyroid hormone. Parathyroid has a similar mechanism of action as calcitriol. So I'm going to focus on the negative feedback loops for calcium homeostasis. And if you are exhibiting hypocalcemia, parathyroid hormone is actually secreted from your parathyroid, and it will raise your calcium levels by increasing bone resorption through osteoclasts, reducing osteoblast activity so you don't deposit more. And then through the kidney action, it has more phosphate being excreted and less calcium being excreted, which less phosphorus in our body or phosphate in our body actually prevents hydroxyapatite from forming, so you have less deposition. And then by having less excretion of calcium, you're conserving the calcium in your blood. If your blood calcium level goes above normal, calcitonin kicks in. Calcitonin got its name because there's these special cells called clear cells or C cells that are found in the thyroid gland that become active when blood calcium levels rise too much. What they do is they increase osteoblast activity, so they deposit more bone, and they reduce osteoclast activity, so it's resorbing less bone. So how do you remember which one is which? There's a couple mnemonic tricks that I've come across over the years that may help you. Calcitonin, because of the T in the word, it's secreted by the thyroid and it tones the bones, meaning it lowers your calcium and stimulates your osteoblast activity, increasing your bone density. PTH, you could think of it being the parathyroid and it's voiding the bone of calcium. Another way to think of it, calcitonin, it has in it and it's calcium into the bones, while parathyroid is a void of the calcium in the bones. So there's lots of little mnemonic tricks that you can pick up to try to help you remember these things. So what's the implication of suffering from hypocalcemia? So there's two disorders that your book actually talks about in one of the deeper insights, and this one is the rickets and osteomalacia. So if you have an inadequate amount of calcitriol, so this is not enough vitamin D, what ends up happening is when you have bone deposition, you're having more the collagenous material deposited as far as the matrix goes, and less of the hard material in the form of calcium carbonate and the hydroxyapatite. And it can lead to abnormal bone softness in children, which is referred to as rickets, and that's what's depicted in this figure, as well as osteomalacia, which is the same type of disease, but in the adults. The other bone disorder that we tend to talk about a lot is osteoporosis. This is actually the most common bone disease, and it's when you suffer a severe loss of bone density. The bone will lose its mass and it becomes more brittle due to the organic matrix and minerals no longer being present. This affects your spongy bone the most, since that is where the most metabolically active part of our tissue is. This can honestly lead to lots of hip fractures, wrist fractures, vertebral column fractures. And in order to maintain the bone itself, estrogen is really important. It's one of the reasons why you tend to see osteoporosis more readily in women than in men, but estrogen is important in both men and women for bone density. Postmenopausal women are at a bigger risk because ovaries stop secreting estrogen, and by the age of 70, there's an average bone loss of like 30%, which is absolutely amazing to me that you can lose that much. It's also seen in young female athletes because they have low body fat, which causes them to not produce as much estrogen. Treatments for this, there's estrogen replacement. There's other drugs such as PTH itself, so taking parathyroid hormone as an injection, but the best treatment is going to be prevention. Exercise and good bone building diets between the ages of 25 and 40 are really going to be what help maintain your bone's integrity over life. And if you can keep up the exercise and good bone building diet, meaning you're getting enough calcium, you're getting enough vitamin D, you can have really strong bones even into your 60s and older. The other thing that your book always goes into is the effects of one system on all the others, and the effects of the skeletal system on all of the other organs. It has to do with the relationship between what actually is going on in our bones versus the other systems. So when it comes to the integumentary system, which is the other system in this exam, the bones lying to this close to the surface help to maintain the support, but the integumentary system's processing of vitamin D is integral in the skeletal system. The muscular system helps with our movement by attaching to the bones. Calcium homeostasis is maintained through our endocrine and nervous systems. The circulatory system's attached to the skeletal system based on the fact bone marrow is where our blood is formed. So lots of connections between these. Take the time to read through them and become familiar with them. And the last thing that I want to address, because every chapter that we deal with the skeletal system, I want to focus on aging and senescence. Remember that aging is the normal occurring changes just from growth, development, and degenerative changes that happen later in life. And then the degeneration that occurs in an organ system after the age of peak functional efficiency has happened is the senescence. Really, when we deal with healthcare, 1 in 9 Americans 65 or older are experiencing some type of senescence. And please keep in mind that when one organ system starts to experience it, that it can lead to the senescence of other organ systems. And not all organs degenerate at the same rate. Some will be very moderate and slow, and others will be pronounced and quick. For the skeletal system, we've already referred to osteoporosis, and this is typically when you lose enough bone mass, and after 40, it's thought that women lose about 8% of their bone mass per decade, men lose about 3%. And this is truly because osteoblasts simply become less active than osteoclasts. But if you stay physically fit and active and you're eating healthily, it can help with the bone remodeling and to keep your osteoblast activity continuing. Osteopenia is loss of bone mass before it gets diagnosed as osteoporosis. So those are the key takeaways from the bone chapters. If you have any questions, don't hesitate to reach out to your instructor.